am going to introduce our speaker. This is an interesting topic. Dr. Womack is one of our PCPs, and he had a patient that had a swollen arm. This is a case study, basically, of that. Dr. KathyLee Santangelo is a cardiovascular surgeon. I got that right. Doing veins at Totality Vein Clinic. And Steve Bernhardt is a medical ultrasonographer. He's going to also speak on it, on how they identify the issue. And I'm going to introduce Dr. Santangelo for you. So kind of you. Okay, so it's kind of embarrassing looking at how youthful this audience is, but you know, Steve graduated from the University of Oklahoma, and I did just my thoracic training here in Oklahoma. Steve has been technical director at the Vascular Imaging Center at Ochsner Medical Center he spent 21 years there. In case you didn't know, that's the second oldest vascular lab in the world, right behind Massachusetts General. So between the two of us, we have a combined 60 years of professional experience, which doesn't make me feel that good right now looking at the audience. But anyway, Dr. Womack asked us to present this case, and I just want to tell you that on April 4th, he called us about a woman who had arm swelling, and he had received from a physical therapist a request for the patient to have studies to document her arterial inflow and her venous outflow before the therapist would begin lymphedema management. So he didn't actually see the patient either, which is kind of important for the rest of the story. But anyway, so this patient, on April 5th, we saw her because when we hear about arm swelling, we never know if it's acute or non-acute, and we want to be sure that we get people in to make sure that we do the right thing. So we saw her the next day. She's a 70-year-old obese diabetic woman. She had a history of right leg cellulitis. She was admitted to St. Francis Hospital in Tulsa on February 8th. February 8th, we're seeing her April 5th. Her treatment plan had included a course of IV antibiotics, and she underwent a PICC line to have that therapy. The PICC line was in her left arm, specifically in her antecubital fossa. She had to be discharged on February 20th because of Medicare rules, but on February 19th, she had swelling of her left arm, and it involved her wrist and her forearm, and she was transferred to an LTAC where the rest of her antibiotic course was going to be completed. Within a week of being at the LTAC, her arm swelling had gone from just the wrist and the forearm to her hand and her upper arm. And reportedly, an ultrasound was performed that documented that she didn't have a DVT of her arm. She was discharged from the LTAC, and she was ordered physical therapy. And again, that's how we got involved, because the physical therapist insisted that she had these arterial inflow studies and venous outflow studies in the arm prior to any lymphedema management being performed. So, this is the patient's arm when she came to see us. It's her left upper extremity, and we were told, you know, do an ultrasound, make sure everything's normal so she can go to lymphedema therapy. So we talked with her, we talked with her a bit, and this is her lower arm, and if we could show you, this is in comparison, so you can see the normal right arm, you can see the swelling in the dorsal aspect of the hand, the wrist, the forearm, and if we had comparison pictures, you would be able to see her upper arms were likewise swollen compared with the right side. So again, her family doctor got involved only because the LTAC discharged her and wanted to start lymphedema therapy. And now we do the ultrasound study, and Steve's going to discuss that with you now. So.
Well, even though the patient said she had an ultrasound study, we cannot find it. There's no evidence that it's ever done. Why? We don't know. So she comes to us. We hear PICC line, we hear acute swelling some time ago. So in our mind, we're thinking, well, you know, is this truly lymphedema? So we started doing the ultrasound. You know, they asked for arterial study. So basically, This is your typical ultrasound. You know, this is a transverse image of the subclavian artery. So this is shoulder. You know, this is toward the hand. Of course, now on this young lady, I'll talk about it before. She has a very large thorax. Most vascular imaging is done with a linear probe that is of a megahertz. It only penetrates. You can get to 3 inches. This chest is pretty deep. The vessels are pretty deep, so we chose to use an abdominal probe on her just to get to the depth and show flow within the vessels. Now, you can see this is typical biphasic waveforms. I don't know if you're familiar with biphasic, triphasic waveforms. On ultrasound, a monophasic waveform where it doesn't dip below the baseline is an indication of a narrowing of some sort. Anytime you have biphasic or even triphasic waveforms, that's a sign of normality, whether it's in the legs or the arms, because the arterial flow is going into a high resistant bed. So that's the expected look. And of course, she has a biphasic waveform. And in the legs, it's very common, and most everybody in this room probably has a triphasic waveform. And when the heart pumps its systole, the blood moves into the arm. And then it gets the resistance, and so you get the backward flow in the second phase. How I explain this, if you stand at the beach, the waves come in, and you look at a second ripple going outward, it's a similar phenomenon in the arms, that pressure wave that goes backwards. In the legs, you'll see a forward phase, and that's just the elasticity of the wall, just coiling back. So if you're relatively healthy, you don't have calcified walls, you'll have a triphasic waveform appearance. In fact, in our clinic, and we specialize in vein care, but when we get a patient coming in and we're evaluating legs, and most likely it's going to be a venous problem, we're always putting a Doppler on the distal posterior tubular artery just to make sure that we're not doing any sort of arterial component. You get a triphasic waveform, that's as good as gold, just go on, don't even think it's an arterial component. So anyway, we did this, and of course we're going to couple this with pressures. Velocities are nice in ultrasound to define the degree of narrowing. You know, we look at velocities before and after stenosis to determine the degree of narrowing. It's a physiological, you know, you do angiography, that's more of a visual thing with dye. In ultrasound, you know, watch out when people are talking about degree of narrowing based on visual appearance on ultrasound, they're very, very inaccurate. So we look at the velocity before versus the velocity afterwards, and that's how we determine the degree of stenosis. And I'm going to get so technical, but like in the leg, you get a quadrupling of velocities, that's a 75% narrowing, is basically what that equates to. So, but on this lady, we're going to take pressures, because pressures are very valuable. So we're going to take brachial pressures, we're going to take forearm pressures, just to see if there is a level of, or presence, or what level, if there is a narrowing. So we did a quick arterial evaluation. Although, you know, we're thinking she had a pit catheter, so we're thinking that was probably the issue. Now, this is in her chest, and the probe now is longitudinal, because we're getting a cross-section of the subclavian artery and vein. You can see here, there's the skin surface, here is the artery that you're seeing flow in it, and there's the thrombosed vein. Now, sonographers are really big. Before we had color flow technology, which color flow technology is, if you don't know what it is, this image is made of multiple pixels. Every pixel interrogates the Doppler effect. And so it gives it a color based on blood moving because of the Doppler effect. And so that's what gives that vessel color. Now, before we had color Doppler, which is actually, I clinically worked on it in 1984 before it came to market. Before we had color flow and we didn't see flow moving in a vessel, we did compression technology, where we compressed the vein just to make sure there was no thrombus in it. Well, in this lady, she's got a very large thorax, and there's so much tissue between skin wall and vein, it's really hard to do compression. You've got ribs there, so it's very hard to do compression technology of the subclavian vein. Now, you can do it of axillary, which I'm going to show you a picture of that in just a second. But you can see here in both instances, arrows pointing to the subclavian vein. So this is a transverse vessel. There's no color flow in that vein. Although sonographers, if they're good, they will say, oh, I don't see flow in the vein. Okay, what do I need to do? You need to optimize for very slow flow. These systems are not good at looking at very high flows and very low flows. the operator needs to change the machine to looking for, do you want to look for high velocity jets, do you want to look for low velocity jets? There's something called, on the system, it's called color scale. It's the pulse repetition frequency. It's like cinematography. How many times do you want to sample that every second? Well, you want to sample it fast because you want to look for very slow flow. So you need to adjust that. You need to change what's called pulse repetition frequency, looking for slow flow. We use it every day in vein practices because we look at the functionality of flow in veins, and we want to look at that slow flow. And so you need to optimize that. It doesn't compress, there's no flow. Now here it is longitudinally. Again, this is the shoulder, this is the hand, there's the vessel. Now, I didn't talk about it, but this bar is very important to a sonographer in that it tells me the proper direction. That's shoulder, that's hand. The blood is being seen by the probe is going away from it. That's why it's colored in red, because the arterial flow is feeding the hand. So red is very appropriate in this example. Now here, when we have color bar, it doesn't matter. It's not lighting up in either color. It's thrombus filling the subclavian vein. So again, you know, I know you're probably not going to go to the point of, in fact, we're going to get to this, and that's part of it, is figuring the puzzle out and not always reading a report and assuming it to be gospel. You should be able to look at a report and determine if it was an adequate study and did the truth. So we refer to an interventionalist for thrombolysis or possible thrombolysis. They did a venogram to confirm that we were correct, and yes, the subclavian axillary veins were thrombosed, but the interventionalists deemed that it was beyond the 14 days and that catheter-directed thrombolysis would not be successful. So they chose not to do that. They discussed oral anticoagulation with her. Then we talked about lymphedema management that needed to be done. Because now that even though there probably most likely is a lymphedema component to this DVT, as it started out as a venous outflow problem. And then you need to assess compressive sleep. We put patients in compression that have DVTs, we put them on compression hosts because we're going to be talking about this because there's a less likelihood of valve damage with compressing and keeping all of the sides of the fluids out of the legs as you go forward. Okay, so the three most common reasons for arm swelling: deep vein thrombosis, lymphedema, and cellulitis. Let's start with DVT in detail. There are two types of DVT. Secondary thrombosis of the arm. Secondary thrombosis, of course, is the most common. Upper extremity DVT counts for only about 10% of all DVTs. Catheter-associated upper extremity DVT count for the vast majority, resulting from mainly from central venous lines, with lesser extent of pacemaker leads. Cancer, particularly ovarian, lung, lymphoma, or a person with blood clotting disorders, account for many secondary cases of upper extremity DVT. We're not really going to talk about blood clotting disorders, although in our lab we deal with it on a daily basis. With factor V Leiden and protein C, protein S deficiencies, we do it on a daily basis. We're not going to talk about it here. Primary thrombosis is very uncommon. Effort thrombosis, which usually occurs in healthy young men due to vigorous arm exercise such as weightlifting, playing badminton, pitching baseball, performing competitive overhead activities such as painting, or car repair. I know that weightlifting is a big thing. I worked with 5 vascular surgeons in New Orleans, and we had a couple of cases where people who overdid that sort of activity. We had one was definitely, we're going to talk about thoracic outlet syndrome, but DVT of the arm. The other one was an arterial occlusion. He was a Mississippi police officer that was the size of a brick wall, and his thoracic outlet occluded his artery. We ended up bypassing the artery, and at his bedside, his other weightlifting buds came there, and my surgeon at the time discussed their activities and what it may lead to, and their disinterest in ceasing their weightlifting. So he just said, hey, it's income for me, don't worry about it. So anyway, most patients with effort-related upper extremity DVT have an underlying venous thoracic outlet syndrome. It results in the compression of the subclavian vein because of anatomic abnormalities within the anterior part of the thoracic outlet. Of course, the thoracic outlet is the clavicle, the first rib, and the anterior scapulae muscle. And what happens is because of this repetitive microtrauma to the subclavian vein, it ruins the intima, causes fibrosis, activates the coagulation cascade, and it elicits effort-related thrombosis. That's, of course, called Petschek-Schroeder syndrome. Now, idiopathic, if you have I guess that the message here, though, if you have a patient that has a spontaneous thrombosis, which is uncommon because they're usually sticking things into the veins, what usually thrombosis. But if you don't have a reason, there's no activity, the person's occupation is not raising their hands up, you don't think it's thoracic outlet, it's just all of a sudden we have a clotted arm, then you need to do search for cancers. That or a coagulation disorder. Okay, so complications of DVT. Well, like in our patient, she had persistent pain and swelling. She's still pretty bad off today because she did get catheter-directed thrombolysis. It would be nice to revisit her in maybe about 3 to 6 months to see if there's any recannulation of the thrombus. That would be great to do. Pulmonary embolus, we're going to talk about statistics on that in a second. It's less likely. Recurrent thrombosis, loss of vascular access in that arm. Could be severe if you became a syndrome, but of course you could have bilateral arm swelling. She did not have swelling in the right arm. And I must admit, on most normal-sized adults, it's easy to see the brachiocephalic. You go between the clavicle and the neck, and you can't see it. I have seen the superior vena cava, but very rarely. More cardiac people are usually looking at superior vena cava more than anybody. On this lady, because of her large thorax, you can only see subclavian axilla, so you couldn't get to the SVC or the brachiocephalic. And post-thrombotic syndrome, these are all complications of DVT. Now here's a chart
we just wanted to compare DVT in the arm with the leg, since probably you guys know a whole lot more about DVTs in the leg. So annual, this is the only thing I could find in the literature about that kind of information. So this is a study from Circulation in 2012. Obviously much more common in the leg, 94 per 100,000 versus 16 per 100,000. We used to be taught, when I was where you are in your career, it was extremely rare for an upper extremity DVT to embolize, even though it's closer. But now, with the incidence of central venous catheterization being so common, this incidence is rising, that they get systemic emboli from it to the heart, to the lungs, and DVT, it's still higher, 15 to 29, but this number is like not rare anymore, it's common. Recurrences, not too much difference actually. Once you have a blood clot, you're more prone to have a blood clot, is the bottom line there. And then post-thrombotic syndrome, which is persistent pain and swelling in the extremity, much more common in the leg, but again, rising in the upper extremity as well. This difference in the overall mortality in 3 months, 11 versus 7%. Well, a lot of DVTs are just walking in off the street, coming off an airplane, or having had a knee scope or something like that. Whereas these people who have upper extremity DVTs are in the hospital with central venous catheters. They're the sick people. They're in the ICU. They're being treated for sepsis or something like that. So the mortality can be or is higher in the upper extremity DVT. So,
well, as far as testing goes, beyond ultrasound, again, what we're trying to say here is, as a clinician, putting the puzzle together is the important thing, not relying on any one source. Compression, here statistics-wise, ultrasound is very sensitive, 97%, specificity is 96%, and again, it's very technically dependent. And therefore, DVT is expected clinically, is an essential first test. When ultrasound is indeterminate or considered normal, but it differs from your clinical impression, you should go beyond that. You should possibly consider doing a CTV or a traditional venogram. If you have a very big swollen arm, and they, like this lady, I mean, the minute we knew she had a PICC line, we just knew it had to be a thrombus vessel. Even though she had a normal report, we're not going to let them, every kind of ran with it, they're like, oh, this must be lymphedema. Well, lymphedema is not acute. And this was an acute episode. So, you know, even if we couldn't do an ultrasound because we couldn't scan deep enough to look at the vein, we would be sending her off to get some sort of venogram just to see what's going on. We're not going to stop there. We're just not going to assume it's normal. You know, I don't like the word inconclusive on an ultrasound test. That means kind of like we don't know what we were doing, and that's what we're going to put on paper. It's like, no, just say maybe test couldn't be done, go to the next best test. It doesn't stop there. Lymphedema, which Dr. Santangelo is going to talk about, that's something that can be done to define lymphedema. You're going to be looking at white blood cell count on the CBC, which will maybe bring in the diagnosis of cellulitis. One of the first things you should do, I guess, for both leg and arm is do a D-dimer. Because, of course, a normal D-dimer is going to rule out DVT. A lot of people, you know, in the ER, if they get a normal D-dimer, they won't even bring in a sonographer to look at an ultrasound, which is very appropriate because there's very little chance that you're going to have a DVT. So treatment. There's two ways you can go with this. Most everybody in America is just going to systemic oral or IV anticoagulation therapy, which is the standard of care. I must admit, we've been a little more aggressive with, especially in the legs and arm, when we see patients with acute DVT, and it's always knowing when the onset of their symptoms were, is what is important. And we go to percutaneous transcatheter thrombolytic therapy. It basically is removal with catheter-directed thrombolysis, mechanical thrombectomy, angioplasty, possibly stenting in place if you think you need to be stented. Observational studies from the University of Washington demonstrate that early lysis results in preservation of valve function, which I think that's why we do it. You know, if we get a person coming to us with a DVT, we're going to try to thrombolysis to preserve their valves. We have so many patients in our practice that have post-thrombotic syndrome, and once you get post-thrombotic syndrome, you have it for life. There's nothing that can correct it. There's a gentleman in Mississippi who claims to be able to reconstruct vein valves, and I don't think we're on board with that. So once you have, and most people can't afford that anyway. So you don't want to get post-thrombotic syndrome at all costs. So that's why we're about going and trying to get the thrombus out early to prevent the post-thrombotic syndrome, whether we're talking arm or leg. Success of that catheter-driven thrombolysis, again, is depending on the age of the clot, which needs to be determined not really by ultrasound, but by the onset of symptoms. Now, the American College of Chest Physicians and Society of Interventional Radiology recommended catheter-directed thrombolysis, the only done in patients with extensive acute thrombosis. That is, in the arm, that would be the subclavian vein and the axillary totally occluded, less than 14 days prior to early symptom relief, to provide early symptom relief, and we want to prevent post-thrombotic syndrome, and we want to prevent pulmonary emboli. Okay,
we're going to shift entities now to lymphedema, which basically is an abnormal collection of protein-rich fluid in the interstitium, resulting from obstruction of lymphatic drainage. And the obstruction can increase the protein content in the extravascular swelling of the extremity. So, sorry. This is why he doesn't talk, because he's a professional speaker and I'm not. Lymphedema, most of the United States is secondary lymphedema, 90% of it. The most common causes are cancer, breast cancer. You guys have probably seen women who've had breast cancer with lymphedema of an arm. You get it from radiation therapy. Used to be radiation of the pelvis was very common, and people would have it in the leg. Surgery, in the days when I trained, we were doing mastectomies in general surgery for breast cancer, which we don't even perform any now. We used to do axillary node dissections, and that would cause lymphedema of an arm. And then infections, and certainly in third world countries, filariasis is one of the more common infections that causes lymphedema. But Steve has a couple interesting stories about it.
I always tell this story because, I mean, this isn't a third world, well, maybe New Orleans is, but after graduating from the University of Oklahoma, I went and took a job at Oxford Medical Center in New Orleans, big hospital. And I was very fortunate to train under Francis Casimir. He was one of the big docs at Mayo Clinic. He actually was one of the doctors who started the Mayo Clinic in Scottsdale. He was a vascular medicine doctor. I respected him intensely. We worked together. he's kind of a nerd. He told jokes in Latin, which nobody got, but that's okay. But for about a 2-year period down in New Orleans, we would have these elderly women coming in with one arm swollen. And he would just get me to do an ultrasound, just make sure we're not dealing with any sort of vein thrombus or anything like that. They were all normal. This went on for like 2 years, and one day he stopped me in the hallway and he goes, and I said, Dr. Casper, what is the deal with all these old ladies in New Orleans with one swollen arm? He goes, you don't know? I'm like, yeah, that's what I'm asking. No, I don't know. And he goes, they all have one thing in common. And I said, all these old ladies have one thing in common. And I said, I had no clue. And he goes, they're all rose gardeners. And he used to do the hour-and-a-half physical history on it. So he knew, what they baked for dinner that night. And he goes, no, they're all rose gardeners. And I go, well, okay, what's up with that? He goes, they don't wear gloves. He goes there, in New Orleans, the growing season is 24, all the time. They would prick their finger with a thorn, fungal infection would get into the lymphatics and ruin the lymphatics. He goes, and that's basically all I can do is just tell them what happened, put a compressive sleeve on them, and say, you got to deal with this. So that's kind of a good example of lymphedema, so stay away from roses, that's all I can say.
So primary lymphedema, cases of primary lymphedema, less than 10% in the United States. The congenital ones are easy to diagnose because the babies have a unilateral, usually swelling of the limb, and they just have abnormal lymph nodes and lymphatics. Lymphedema precox usually occurs around puberty or during pregnancy, although it can occur later, but up until the age of 35. And then there's a lymphedema tarda that occurs really rarely. I don't think we've ever seen a case of that, but after the age of 35.
We do veins, but we do a lot of lymphedema patients. Had a lot of leg lymphedema stuff. And actually, we're not even talking about clippertrin A, which is another thing where you have multiple AV, arterial venous malformations down the leg. We've had 3 clippertrin, which is pretty bizarre because that doesn't come around very often. But we did with Meeks disease, we did have one young lady from, I don't know, Meeker or some rural, she was 16 years old, which is a definite Meeks patient. She's a basketball player. She sprained her ankle at a certain age on the basketball court. And here, a year later, she has persistent leg swelling, has been to everybody. And they're thinking they're coming to us that we have the vein solution for her, because she's a pretty little lady and she doesn't want a swollen leg. And so, actually, I don't cry in front of my patients very much, but I think I did. This cute little girl comes in, this is April, prom season. She doesn't care, she just wants to look good on that day at her prom. So we're telling her that no, previous diagnoses are correct, it's Meeks. Your trauma to your ankle initiated your lymphedema, and now this is something you got to deal with. So I didn't know what to say to her, so I said, listen, we can get you in a compressive sleeve. When you get them in a compressive sleeve, we can equalize the legs so they look good. Yes, you're going to have to wear it for life. You don't want to have skin changes, you want to break down. But listen, that prom's in a month. We can get that leg down, and you simply pull that down sleeve off, get your mascara on, get that dress on. You look good for the night. But the next morning, you put the sleeve back on, okay? And so she was good with that we could get her looking good but it was very sad. I was very upset for her that was going to be her way of life at 16.
So signs and symptoms, obviously chronic swelling. 80% of lymphedema cases occur in the legs as opposed to in the arms. Recurrent infections, we see a lot of patients who have had cellulitis 7, 8, 9 times and lymphangitis. Many of the patients in the later stages of the disease have skin pathology, including fissures, ulcers, verrucous changes. These people, before they get to the non-pitting edema stage, often have fevers, chills, and just generalized weakness. They get fatigued due to the size and the weight of the extremity. They have impairment of their daily activities, especially when it involves the hand. They can't open a door. They can't take a lid off a bottle of water. They get recurrent bacterial and fungal infections because of the fissures in their skins, and they have recurrent episodes of cellulitis. So it's a pretty disabling disease. The diagnosis is mostly made on physical exam, or many times made on physical exam. It's this non-tender pitting edema early, And then later it's the, pitting edema early and non-pitting edema later usually causes radial enlargement of the extremity. It causes erythema of the affected area initially and then thickening of the skin until it becomes a peau d'orange, which if you guys haven't seen because of modern medicine, it really does look like an orange peel. They get a woody edema and you feel their legs and they're like tree trunks. It's almost like bark. And then in third world countries, not so much here, but actually when I first came to Oklahoma a long time ago, I would see patients. There was one at OU. I remember distinctly. She worked at OU. She had elephantiasis of her leg, of one leg. Its long-term involvement involves cobblestoning with a hyperkeratotic papillomatous lesions that then become crusty and start weeping and oozing lymph, and it's lymphorrhea unless it gets infected, and then it's really foul and disgusting. But anyway, the thing you're taught in school about lymphedema is a positive stemmer sign, which is being able to pinch the web space between the great and the second toe and lift that skin up. And if you can't, then it's a stemmer sign. You can have early lymphedema and have a negative stemmer sign. It's really one of the most unreliable things you'll ever learn.
And a lot of people will have both venous and lymphedema simultaneously. We get a lot of patients that have already been deemed lymphedema, and they come into our clinic, and there's no foot involvement, no stemmer sign. It's like, I don't know, this is good. And they have these huge problems with their veins that we can fix and bring it back to course.
So testing and lymphedema, mostly lymphedema is diagnosis of exclusion, so you want to check a CT scan, an MRI, and ultrasound to be sure the swelling isn't caused by something else. And if you really want to be comprehensive and thorough, you would get a lymphedema. I will say that, obviously we're not talking about orthopedic causes of upper extremity swelling, but if you're concerned that there's a fracture in the arm, just get an x-ray of the arm. But it really shouldn't be a diagnosis that you need imaging for so much. So MRI is somewhat better than CT scan looking at lymphatics and lymph nodes, but really they're both about equal. This is the only lymphedema I could find that would project well, but I didn't know if you guys had any experience looking at these nuclear medicine studies. So this is kind of a brutal test. If you didn't know that, they put technetium labeled colloid in between the web spaces of your great toe and your first toe, and your second toe and your third toe. And then they massage your feet they're supposed to massage them for 30 minutes. And then you're supposed to walk for 30 minutes. And then they take the pictures. Okay,
so then you get a diagnosis that you already knew what it was. So,
okay, so it's really a brutal test, which we don't normally perform. But this is an anterior view of the right leg. That's a posterior view. And you can see that the colloid, the radiopharmaceutical, gets stuck in the right leg, which confirms a diagnosis of lymphedema. I was a heart surgeon for 20 years, but in my 10 years doing this stuff with veins and leg swelling, I have never ordered this test on a patient. I've talked to them about it, but we basically said this is what it is.
There's some mean patients who want to order it.
So treatment of lymphedema is really, in the United States, it's mostly physical therapy. And there are lymphedema specialists, physical therapists who specialize in lymphedema therapy. It involves manual lymphatic drainage. They teach the patients how to do it themselves. They do massage. They do kind of repetitive exercises, occupational activities. And then there's something called cervical stimulation, because everybody knows the thoracic duct empties up here in the left subclavian vein. So in third world countries where they have filariasis, they can use pharmacotherapy, but we don't have much roundworm here, so we don't usually prescribe drugs for that. But is this where you're interested?
No.
So the last topic we just wanted to cover, and I'm sure you guys know more about this than I do, being in family practice, cellulitis, inflammation of the skin and subcutaneous tissues, associated with acute bacterial infection. Usually the bacteria gets in through a breach in the skin, usually strep or staph. The 4 classic signs: it's red, it's warm, it's tender, and it's swollen. So it's pretty easy to make that diagnosis. I think clinically, I guess testing-wise, you get a CDC, make sure they have a left shin or whatever. First-line therapy is oral antibiotics, gram-positive coverage, first-generation cephalosporin or penicillin. People tend to, draw the line of their edema with some indelible marker on the skin of the patient. If 72 hours goes by and that redness doesn't shrink down, then you need to start thinking, well, what else could this be? Is this a methicillin-resistant staph infection? Is there an underlying abscess? What else is going on? So you may need an ultrasound. I think MRI is way too overused for the diagnosis of abscesses in the soft tissue. Ultrasound is a great modality for that. And so you may need to switch antibiotics or even admit them and get them some IV antibiotics. But that's a pretty straightforward problem. In conclusion, we want to emphasize that lymphedema is a diagnosis of exclusion. So we never did see the normal ultrasound report in the patient who came to us. So did she really have a normal ultrasound that showed no DVT? Our impression was that because they used the linear transducer, they never saw the subclavian or the axillary veins because she was a piece that people assumed that she didn't have one and they could have helped her. I think the next thing is that the pieces of the puzzle need to fit. If the lady has a central venous line catheter and she has a swollen arm and she's complaining about it, then you have to prove that it's not a DVT. You really do. That's our job as doctors. And if that had happened early in her course, either at St. Francis Hospital, I don't mean to be disparaging our colleagues, but really, if that had happened at St. Francis Hospital, or if the LTAC had contacted the physician who was making rounds on her, then perhaps this lady wouldn't have a chronically swollen, painful arm right now. And then you have to know the limitations of medical imaging. And Steve could speak to this, but when Steve and I see a patient, I'm the physician, he's the sonographer, we're in the room, I'm talking about her story, or listening to the patient's story, Steve's looking at the images, and our job is to figure out, why does that patient have the problem they have? It's not like the sonographer's going to get this many images and shoot it off to a radiologist who's going to look at it totally out of context and say, oh, there's nothing wrong, or I can't tell, these images are horrible. I mean, that's the way medicine shouldn't be taught, and you shouldn't practice it. So I hope if there's anything you learn that you should trust your clinical impressions. You should really do what you can do for the patient. And honestly, this patient, her primary care doctor is Dr. Womack here in Oklahoma City. She was at St. Francis in Tulsa because her family was up there. So when I said, I really think since you're having still so much pain and swelling, even though it was 6 to 8 weeks past when her swelling started, you should go see this interventional cardiologist. He can help you. She said, no, I want to go to the person who did my husband's 7th coronary stents. And I said, well, he may not be the best one at upper extremity DVT because it's a different animal. It's not the same as a coronary artery problem. And so it was a difficult situation. So I wish that Dr. Womack had allowed us to present a case where we really helped the patient, but that's not what happened in this case. And I hope you learned something from us.
We're not too thrilled about that 14-day mark too, because the 14-day, oh, don't even try. We've got a few people here in town who are aggressive.
Yes.
And we love their aggression because we had a patient the other day that had a DVT. He had chronic thrombus throughout his leg system. And I mean, to the point of it only being like a thread open. He was recanalized, but barely recanalized. And we've been monitoring this guy for a long time. Okay, here he comes. He gets another DVT, acute on chronic. Thrombos the whole leg. We sent him to one of our aggressive interventionists, chronic, acute, or whatever. He sucked every little bit of thrombus out of that vein. Now the guy's got a perfectly open vein. So, I mean, sometimes I think it's worth trying. If they fail, they fail. It doesn't hurt anything. And in this case, we thought that they should have been more aggressive and went in and tried to thrombolyse it. If they failed, that's okay. We're treating with oral anticoagulation, but we thought it should have been a more aggressive treatment in our opinion. So.
Mostly because the patient was still symptomatic. If she had come and her arm weren't still swollen and painful, then that would have been a different story. But so that's us, and that's our case with Dr. Womack.
This is where we work, Totality. We're actually, as far as accreditation of facilities, there are two the American College of Radiology and I used to actually be on the board of the Intersociety Accreditation Commission. These are the only two people who accredit imaging in the country. Although the IAC only accredits vein centers, and we happen to be the only accredited one in the state.